and welcome to the Dr. Bob Show. We'll be spending most of this show talking about reflux disease, reflux of stomach acid up into the esophagus, gastroesophageal reflux disease, GERD. It seems like everybody I see in private practice has reflux disease. Why is that? Are more people getting it? Is there a reason for that? Is it dangerous? We'll be answering those questions on this show. My guest is Dr. Raj Narayani. Dr. Narayani is a board-certified stomach specialist, that's gastroenterologist, and he'll be answering our questions. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about treating the allergic nose. It may be more difficult than you think and more important than you think. And if we have time, we'll be talking about blood in the urine. Is it always dangerous? Is it a sign of cancer, or are there other things? It's very important that it be evaluated. A lot of information for you. You'll want to stay tuned. We're talking with Raj Narayani, board-certified gastroenterologist, stomach specialist, and we're talking about reflux disease. Raj, welcome to the Dr. Bob Show.
Thank you for having me, Dr. Bob.
You were a guest before and you did such a good job. I'm looking forward to this show. Tell me, what is reflux disease, or what is GERD?
So GERD, or gastroesophageal reflux disease, is a condition where contents in the stomach, acid, bile, food content, can actually come up across the valve that separates the esophagus and the stomach, and then end up in the esophagus and create injury in that location or symptoms.
So when we swallow food, it can come back up?
It can come back up.
Why does it do that? Are there normal safety mechanisms that normally make that where it doesn't occur?
Yeah, so we have a valve in place at the bottom of the esophagus and the top of the stomach that serves as the sort of defense mechanism against anything coming back up. But in the case of gastroesophageal reflux disease and heartburn, sometimes that valve may not function normally. Oh. So there might be times when it relaxes at inopportune moments, and there might be times when it's just under a very low level of pressure.
So when I swallow a hamburger or vegetables and fruits like we're supposed to be eating, and it goes down the esophagus, it goes to the lower part, how does it get through that sphincter? I thought a sphincter tightens up thing. How does it get through that?
So the sphincter muscle at the bottom of the esophagus is designed in a way to relax when we're eating as part of the normal function of the esophagus.
Pretty cool.
And then to close again after the meal ends up in the stomach so that it doesn't allow contents to come back up. But if it relaxes again at times after meals, or if it's under a low level of pressure all the time, that allows the contents of the stomach sometimes to come back up, because the chest is usually under negative pressure in order to allow your lungs to expand when you breathe, and the stomach and the abdomen are under positive pressure. So positive pressure may force contents into a negative pressure cavity.
So the gravity wants to push that food back up, but there's a sphincter normally that keeps, if it doesn't work well, the food or the acid comes back. How acid is the food in the stomach? Is it raw? Really acidic?
It's very acidic. It has a pH that approaches the level of other acids like battery acid, and so even if you come in contact with it on your skin, it can actually burn you. And so because of that, and because the esophagus isn't built to withstand that kind of acid insult, acid can come up and either cause symptoms or it can cause burns or injury in the esophageal lining.
Now, everybody that I see in current practice seems to have reflux disease. Is it because we're diagnosing better? Is it because we've got other problems that leads to reflux? What's the problem?
I think it's actually a combination of a lot of different factors. I think there is some truth to the fact that we're looking harder. I think patient realization for risks related to reflux has led them to come see the doctor more often. That's part of it, but I also believe that it has something to do with what we are doing as a society. I think because of the obesity epidemic in this country, and because perhaps we're consuming more coffee, that we're seeing behavioral habits that promote reflux more commonly in people.
So if somebody's overweight, that puts a big belly, puts pressure on the stomach, and it pushes it back away. Pregnancy do that too?
Pregnancy can, and it's interesting that in pregnancy you can actually have reflux during any of the trimesters, but it's most commonly seen in the first trimester and probably has a combination of not only pressure in the abdomen but also hormonal influences from the new baby.
So what does coffee do with that? It just increases acid, or to do something to the sphincter? And how about cigarette smoking?
So with coffee, the caffeine has been scientifically shown to reduce the tone of the sphincter muscle at the bottom of the esophagus, and that's probably the main mechanism by which caffeine and coffee then promote reflux. With cigarette smoking, it's the nicotine in cigarettes that seems to promote reflux by virtue of the same mechanism, basically relaxing the tone in that sphincter muscle and allowing it to stay open for longer periods of time.
So there's lots of scientific reasons that we're having now that acid from the stomach can reflux up. Are there certain kind of foods, or is it just the volume of foods, or both, that can cause reflux from the stomach up to the esophagus?
It's actually both. If you have a large meal, and particularly if that meal is a fatty meal, then that can actually create a chemical situation that allows the sphincter to relax at inopportune moments, particularly after those meals. If you consume certain foods that are spicy, certain foods that have citrus content, then even on the way down, they can sensitize the esophagus a little bit and create a tendency to get heartburn more frequently from even small amounts of reflux.
Now, fatty foods, what they do is what that creates this? They make it where the food doesn't go out of the stomach?
So fatty foods will sit in the stomach longer. We know that scientifically as well, that fatty meals and even high fiber meals can sit in the stomach for extended periods of time. And so the longer a food sits in your stomach, particularly if you eat that meal late and then you lay down and you take gravity's effect away, that can promote reflux back up as well.
The side effects that somebody has, what are the symptoms that they do have with this, symptoms rather than side effects?
So if they have a reflux event, they can get the most common symptom, which is heartburn, or a sense of a sourness or raw sensation underneath the sternum or the mid bone here. They can also develop a sense of liquid coming up. We call that regurgitation. It is different from vomiting. Vomiting is associated with nausea and with retching, but with regurgitation, it is an effortless event. So even if you bend over to tie your shoes, or if you lay down on the couch, you may develop, burp up a little bit of liquid that comes up. And then chest pain can occur because of the spasm induced in the esophageal muscle wall.
What's that chest pain like?
It can actually mimic in many ways what you would feel if you had an anginal attack or a heart attack. But it tends to be a real deep level pain. It almost feels like a squeezing, and it can radiate into your back a little bit.
And since it's associated with swallowing, it's not associated with activity or exercise or some of the normal heart factors that we have. While we're talking about symptoms, can there be symptoms outside the chest that this reflux can cause?
Absolutely. So patients who have acid reflux can still develop discomfort in their belly that mimics or feels a lot like an ulcer type of symptom. There are some subtle differences.
Can mimic ulcers?
They can make ulcers as well because of increased acidity.
And can it cause any problems with the throat or hoarseness?
So you can actually develop symptoms in the throat like hoarseness, like cough, like throat clearing because of either one of two mechanisms: acid coming up from the esophagus as it's refluxed into the larynx and touching the vocal cords, which are exquisitely more sensitive to acid content than even the esophagus is, or by means of a reflex that occurs when acid touches the esophagus, works through the nerves outside the esophagus, but connect directly to the larynx or to the lungs to create either bronchospasm, where the airways get tighter, kind of feels like an asthma attack, or the hoarseness mechanism in the larynx.
So people are doing that. It could be because swelling of the throat from reflux disease rather than drainage, rather from an allergy, and you've got to be able to differentiate that. If somebody's asthma is getting worse, it could be a reflex from the reflux that causes the lungs. It's getting more and more complicated and more important that the stomach specialists make that diagnosis. So how is the diagnosis of reflux made?
Typically when a patient sees a doctor for evaluation of reflux symptoms, the first thing we'll do is take a history, listen to their story, see if it fits a reflux type of problem. And then if there are any alarm features or if there are factors about the patient, including their age or their ethnic background, that increase their risk of complications from reflux. The most common test that we will typically recommend is an upper endoscopy.
So that's an EGD, esophagoduodenostomy. So you look down somebody's esophagus.
Correct.
What's it look like?
So the esophagus looks like a straight, hollow tube. It has a pinkish white lining, and typically it's about maybe 2.5 to 3 feet long. And then when you get to the bottom, you'll see that sphincter muscle. It might look like a pucker, unless, of course, it's not functioning well, in which case it may even be open. But as soon as you get down to the bottom of the esophagus, you enter the stomach immediately, and then you'll notice the difference because the stomach is a bigger cavity, it's darker, and it requires more air to inflate.
That must be neat to look down and see the inside of the esophagus and enter into the stomach. Can you diagnose reflux disease while you are looking at the esophagus?
You can in some patients, it depends.
And that's what we're going to be talking about when we come back. In some patients, you can actually see the reflux or make the diagnosis. You're going to want to stay tuned. We're going to be talking about how difficult is an EGD, and if we find there is GERD, reflux disease, what is the treatment? It's really exciting, and what we can do for it. Well, you'll want to stay tuned. We're talking with Dr. Raj Narayani, board-certified gastroenterologist, stomach specialist. We're talking about reflux disease. When you swallow, it goes down to the end of the esophagus, a swallowing tube. And at the end of the esophagus, there's a sphincter, automatically relaxes when we eat, lets the food in, closes up, doesn't let it come back unless there's a problem there and you get reflux disease. Pressure in the stomach pushes the food back up. When you look down with an EGD, you can see that sphincter area. Is that pretty good sort of review?
That's perfect.
So when you look down with an EGD, I think it's fascinating that you can do that. What do you see that makes you think the patient may have reflux, or how do you make the true diagnosis?
So there are a few things you might see. The first thing that we do is look at the lower few inches of the esophagus, because if you're going to see acid reflux injury, that's usually the location you'll see it. And in particular, what we're looking for is evidence of acid burns in the esophageal lining. So you'll actually see erosive changes or ulcers in the esophagus from the damaging effect of the acid itself.
How big are they? Pinpoint or as big as your fingernail? Those ulcers or the redness that you, what's it look like?
It'll vary, again, depending on how much acid truly is coming up. If it's a lot of acid, they may be as big as your fingernail. If it's a lot less, then it may just be small areas, maybe hairline style diameter. They will typically be in more than one area. They might be in 4 quadrants of the esophagus because acid may splash in different places as it comes up.
So if you've got heartburn, that's at the lower part of the stomach, that's pretty near the stomach, so do you have to make a differential diagnosis of stomach cancer? That's why you go down and look, and heartburn from an ulcer or even a duodenal ulcer further down the stomach. You can make the differential by doing the EGD.
Correct. You can look at the esophagus first, then of course part of the examination allows you to look at the stomach and then the duodenum. And so as you look at each individual organ, you can decide if an ulcer exists in one location or the other.
You all are amazing with able to do that. Let's talk about if you establish the diagnosis of GERD, reflux disease, what's the treatment?
The treatment is to educate and advise the patient on mechanisms by which they may be promoting their own reflux, and then help them to cut down on those factors. If they are consuming alcohol or smoking, try to advise them to stop doing that. If they are consuming foods that promote reflux, teach them how to eat so that they can stop doing that. Of course, if they're overweight, we always educate our patients to lose weight for that and various other reasons.
Isn't everybody in our society overweight except maybe you, Raj?
I don't know about that, but unfortunately I think we are dealing with an obesity epidemic in this country.
It's a huge problem. And how important is it in improving reflux?
So many studies have shown now that if you lose weight, you will not only limit or reduce or completely eliminate your reflux symptoms, but you'll also reduce the risk of complications from reflux as well.
So we call these lifestyle changes, losing weight, changing what you eat under the direction of the doctor. What kind of medicines are available?
So we've had a lot of medicines for a lot of years, and of course, decades ago we were using antacids.
Pumps for the tummy, Malox.
Correct.
The ones that we don't see too much over
That's
the
right.
drugstore.
Yeah, and they're still available for people who have very infrequent reflux symptoms and just want to take something to get their symptoms under control, while they may be so infrequent. The mechanism by which they work is that they neutralize the acid in the stomach, but that is temporary because we make so much acid throughout the course of a day. So about maybe 20 or 30 years ago, the H2 blocker, histamine blocker medications came out. Zantac, Tagamet are examples of those. And they work on one specific receptor on the cell in the stomach that produces acid. And so they really only partially cut down the amount of acid the stomach makes. And then in the early 1990s, the proton pump inhibitor class came out.
Proton pump inhibitor, PPI. Everybody hears the word PPI. It means proton pump inhibitors. That sort of really has come into really being effective. How does it work?
So proton pump inhibitors don't work at just one of the receptors on the parietal cell in the stomach. That's the cell that produces the acid. They actually work on the other end of the cell where all the acid comes out. So they actually block the outlet of the acid from the cell rather than the stimuli for acid being produced in the cell itself.
Oh, so that's a pump. How do they block that pump? How do you tell somebody to use a proton pump inhibitor? What are some of the names of proton pump inhibitors?
So there have been a lot on the market. Prilosec was introduced in the early 90s as the first one, and it has since become generic and has become over-the-counter. Prevacid, Nexium,
the purple
Protonix.
pill.
The purple pill is Prilosec and Nexium, of course.
Now they're generic. Are the generics as good, Raj?
Well, I think that's a big debate. I mean, it's tough. You'll hear patients tell you that sometimes they're not as good, but generally speaking, they seem to suppress acid as well as the trade name counterparts.
Good. Proton pump inhibitor. When do you take them, and why do you take them that way?
So you take them 30 minutes before a meal, typically.
Why 30 minutes before a meal? I thought the meal is what stimulates the stomach.
That's correct. And so, I think the misconception has always been that I should take it like an antacid because I've got food in my stomach, I've got acid bathing it, and I need to put the fire out. So let me take this pill now as I've just eaten this meal or right after my meal. It turns out that with proton pump inhibitors, you're not really neutralizing any acid as it sits in the stomach. You're actually taking the pill, having it get absorbed into your bloodstream, circulate back around, and then come back to the cells in the stomach and concentrate themselves in the stomach cells to block those pumps. So the best time to take it is 30 minutes before a meal because that's really when your proton pumps in your stomach are being revved up. They're getting ready to digest a meal, and so you have the highest concentration of proton pumps in your stomach, and that's when you should take that pill because then you're blocking the most pumps you can.
So if you take it in the morning, you wake up, you take your pill, and be sure you eat in 30 minutes. Any certain kind of foods you should eat for breakfast that are good foods and that stimulate those pumps so they can be blocked?
Yeah, it probably doesn't matter so much the content of your meal, just that it's a healthy meal and it's not too fatty. And then for lunch and dinner the same way. But as you know, for reflux, the tenet usually is that you should try to make your dinner meal your lightest meal because that's the time you're getting ready to get ready for the end of your day and lay down. And so you don't want to have excess quantities of food in your stomach ready to reflux back up after that.
One of the things I got to ask you about, and that's nighttime activity, not eating before you go to bed so the stomach won't be full, so that when you lie down, that was my mistake. I did not ask that. So how effective is the PPI?
Proton pump inhibitors are very effective. They've revolutionized the way we manage reflux over the last 20 to 25 years. Generally speaking, they will take care of heartburn complaints in patients about 90 to 95% of the time. And if taken appropriately, they will actually heal erosions in the esophagus about the same rate.
Wow. So we've got good medicines, we've got good treatment. Is surgery ever indicated? And what's the name of that surgery? We just got a minute to go. What's fundoplication? I'll jump to it.
Fundoplication is a plication of the fundus of the stomach. The fundus of the stomach is the top part of the stomach, and when you plicate it, that means you wrap the stomach around the bottom of the esophagus to basically intensify the pressure in that valve that isn't functioning very well anymore. And surgery is indicated for reflux in many cases, typically for patients who've taken medication but aren't fully better on it, or patients who are very young and don't want to deal with the prospect of being on medication for reflux for a large part of their life.
30 seconds. What's Barrett's esophagitis? How important is it? And can you treat it?
Barrett's esophagus is one of those complications of reflux a lot of patients dread. They read about it. It's a condition where the esophageal lining changes, particularly where acid reflux is most concentrated in the lower part. And it becomes a lining that looks a lot more like the intestinal tract or the stomach. And in so doing, then, mutations occur in those cells and in their DNA. And because that happens, then that puts patients at risk potentially for developing cancer in those cells.
Can you see Barrett's esophagitis when you look down?
It's readily visible when we do an endoscopy.
Is it treatable?
It is not treatable in the sense that you can't make medication take it away, but you can actually utilize techniques to destroy the Barrett's if it looks like it's headed towards cancer.
Raj Narayani, I just want to do cartwheels just listening to you because you're such a good teacher. Thanks for coming to the Dr. Bob Show.
Thank you for having me, Dr. Bob.
Isn't that amazing, and isn't that a wonderful discussion? If you've got heartburn, reflux, acid indigestion, be sure that you get it evaluated properly. And now we're going to be coming back talking about treating the allergic nose. It's more important than you think. And if we have time, we'll be talking about blood in the urine. Does that mean cancer, or is it something else? You'll want to stay tuned. I want to thank Dr. Raj Narayani. Wonderful discussion on reflux disease. If you've got it, get it treated. And now for questions from you, the viewer, that I think will be important to your health. Question number one, Dr. Bob, could you discuss how to treat an allergic nose? Well, that sounds simple. Allergy sounds simple, but let's talk about the nose when it's a bummer for a nose. Stuffy nose, drainage, runny nose, sneezing. It can be seasonal in the spring and the fall, or it can be all year round. How do you know what you're allergic to? You have to have it identified. You have to have testing that will tell if you are allergic to pollen, to dust, or to mold, and then treatment will be effective. About 45% of people that are skin tested are negative in their skin testing. They have a non-allergic nose, thinking they've got an allergic nose. Skin testing will tell. And then we treat with medications. The best medication is an intranasal steroid, a cortisone spray. When we spray it into the nose, you have to spray toward the outside. Otherwise, if you spray straight up, you'll start getting a little bit of nosebleeds. The intranasal steroids will tell the allergy cells in the nose to get out of there. The stuffiness and the drainage will leave. You need an antihistamine. So there's a topical antihistamine that's real good called Astelin. Generic is azolastine. Or there's a combination of the two, a medicine called Dymista that has both in there. Dymista is the best new medicine for treatment. One spray each nostril twice a day. Despite all the medicines, the literature says that patients are not satisfied with their medical treatment, that they still have sniffles and snorts and sneezing. So if you identify there's allergies and the treatment is not as good as you want, you might consider a desensitizing program, allergy immunotherapy. It's the only way to challenge and to trick your immune system where your allergies can go away. Fatigue from allergies, that can be gone. Symptoms from allergy, that can be gone. Secondary problems with allergy sinusitis, that could be gone. Good luck on that. Question number two, Dr. Bob. Is blood in the urine dangerous? Well, I think that's a leading question. Certainly it is. Anytime you have blood in the urine, it's serious. We used to be taught that if women have it twice, it has to be evaluated. If men have it once, it has to be evaluated. Where can blood in the urine come from? Well, let's talk about where urine is made. That's where it can come from. The kidney makes the urine. So if there's something going wrong in the kidney, infection, tumor, stones, kidney stones in the kidney itself can cause bleeding in the urine. If you've got blood in the urine that persists, you should see a urologist. From the kidney, it goes down into the ureter, and from the ureter, it goes into the bladder. The bladder is another area that can cause bleeding. Cystitis is frequent in women. Cystitis can cause bleeding. In men, it can probably be a sign that there could be cancer. So blood in the urine in men, you have to have it evaluated. Women, talk to your doctor and be sure that you get it evaluated if you have blood in your urine twice. We go from the bladder to the urethra. In the urethra, we can have several things that will also cause blood in the urine. The female urethra is very, very small, so you have to be careful that you're not getting infection there, causing bleeding. In men, the urethra goes through the prostate gland. If there's something in the prostate gland, then that could cause bleeding. Infection can cause bleeding, both in men and women. So if you've got blood in your urine, pay attention to it. It's not bad to have it. It's bad not to get it treated. So that's all the time that we have for the show. Remember, exercise, how important it is to your life. Remember, 7.5 hours sleep. If you get good sleep, you're going to feel good. You're going to perform well. Remember to eat properly. More fruits, more vegetables, more fiber. You'll stay healthy with eating the proper foods. Eat less fried, fatty foods. Look at your portions. Be sure your portions are low, and you'll watch eating improve your life. And most of all, what is it we like on the Dr. Bob Show? Well, it's that laughter in your life. You know, if you can sit down and laugh, read Facebook, read the comic books, talk with people, have friends over, play cards, laugh and giggle about stories. And the more you laugh, your immune system will work better. So find that person that you like to laugh a lot with, laugh a lot, and you will stay healthy.